Sir, you are in live. Please start your session.
Thank you. Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Our journey began in 1993 and we have 30 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, we are amongst the largest manufacturers of ARV, APIs and FDFs in the world. We have Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare, the 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, for which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar, role of Oseltamivir in flu management. We have got Dr. Prakash Vaidya with us as moderator. Welcome, sir. And Dr. Mukesh Sanklecha and Dr. Anil MU as speakers. Welcome both, sir. Welcome, Dr. Mukesh. Welcome, Dr. Anil.
Thank you,
Dr. Prakash Vaidya is MD DCH with Diploma in Pediatric Sleep Medicine from GCI University of Colorado. Sir is attached to Fortis Hospital in Mumbai and Child Health Clinic Mumbai. Sir is Senior Pediatrician with Special Interest in Pediatric Pulmonology. Dr. Prakash Vaidya is Joint National Convener, Asthma Training Module, Revision 21-22, Co-Convener and Writing Committee Member of Under 5 Wizard Module of IIP, Writing Committee Member of Writing Antimicrobial Response Module of IIP, National Trainer for IIP, NTP, TB Module, NRC Cup Module, etc. Sir has done many presentations as faculty at IIP and other platforms. Sir is past president of IIP Thane chapter. Dr. Mukesh Sanklecha is consulting pediatrician at Bombay Hospital Institute of Medical Science, Mumbai, and Sefi Hospital, Mumbai. Sir has been practicing for past 30 years. Passions has been pediatric allergies, pediatric asthma, pediatric infectious disease, and teaching. Dr. Mukesh has more than 45 publications in Index, Indian, and national journals, and has been a faculty in large number of national and international conferences. Welcome, Dr. Mukesh. Dr. Anil MU, sir is MBBS MD in Pediatrics with Fellowship in Pediatric Critical Care and Diploma in Allergy and Asthma. Lead Consultant Pediatrics and Pediatric Critical Care, Sparsh Hospital, Bengaluru. Welcome, Dr. Anil. And with this brief introduction, I hand over the session to Dr. Prakash Vaidya. Over to you, sir.
You're muted, sir.
Sorry, I'll just share my screen in a minute.
Yes, sir. Yes, sir. Yes,
and
sir.
we'll start. The particular desktop or I where is it called my presentation? Is it wasting my time? Somehow मस्त होत होतं आता काय झालं मध्येच. Okay, is my screen visible?
No, sir.
Ata?
Not yet, sir. Not yet.
Not yet. Not yet.
I never had a problem so far. आता मध्येच काय झालं? Now?
Yes, sir.
Yes,
Now
sir.
okay.
Okay.
It is.
Thank you. So I thank Dr. Prashant as well as Hetero Healthcare for this platform to discuss this important drug. And I welcome both my panelists on board. So I'm going to just make a short talk on the foundation facts in flu, which will discuss about the virus, the disease, as well as the drug. And then we'll straight away go into a case-based discussion of this topic on Oseltamivir in flu management. So the foundation facts now. So we know that we have all been in the throes of a flu epidemic, and we know how many patients have been suffering from flu. The figures worldwide are very, very shocking. 1 billion annual cases, 3 to 5 million cases of severe illness, and almost 3 to 600,000 deaths per year are caused by flu, and a good number will be in India as well. So something about the virus. The virus, as we know, is a single-stranded RNA orthomyxoviridae family of viruses. Now, there are 4 types of flu viruses, A, B, C, and D. Types A and B cause annual epidemics. Type A causes pandemics as well. Type C, hardly any humans get affected, less common disease, and type D is only in cattle. So the viruses of interest to us are type A and type B. Now, type A influenza virus is further sub-classified according to the combinations of proteins on the surface of the virus. Now, this is a diagram of the virus surface. It has 2 main proteins, the HA, the hemagglutinin, as well as the neuraminidase. What does the hemagglutinin do? Hemagglutinin provides the binding site to the virus onto the cell. It allows the virus to get entry into the cell, whereas neuraminidase has got the reverse role. It allows the viral particles which are manufactured by the virus, the virions, to exit the cell. So these two proteins become points of as well as for vaccine as well as for drug therapy. So there are drugs which are anti these proteins, as well as there are vaccines which cause antibodies against these proteins. So influenza A, the antibodies important are neuraminidase and hemagglutinin. As of March 2024, influenza virus circulating are mainly of the subtype A, H1N1 and A, H3N2. But sometimes there are surprise other viruses also. So this is not a comprehensive thing. Influenza B viruses, on the other hand, are not classified into subtypes, but they are into 2 lineages. So the current type B virus belongs to either the B Yamagata or B Victoria lineage. So this is about the virus. What do we know about the symptoms of flu? We all know that flu is a multi-system disease. It causes fever, headache, myalgia, cough, rhinitis. So basically, since it's a multi-system disease, it will cause nasopharyngeal symptoms like a runny nose or a sore throat. It will cause systemic symptoms like high-grade fever, respiratory symptoms like cough, gastric like vomiting, diarrhea, joint symptoms, extreme muscular tiredness because of myositis, and central headaches. So any of these systems or all can be involved, and the duration can be even 7 to 7 days or more. So cold is a milder form of flu. Flu is a severe form of cold, and severity is subjective and inconsistent. Now let's talk of the antiviral drugs that are available in flu. The first drugs that we used were adamantine drugs. This is history now, because amantadine and rimatidine, which were once used, now there is widespread resistance. So this drug is no longer relevant to us. The other drugs that are used are commonly neuraminidase inhibitors. They prevent the release of virions from the host cell, and they are active against both influenza A as well as influenza B virus. Then favipiravir is also an anti-flu drug, and so is baloxavir. Baloxavir is not yet available in our country. So which are the available antivirals in our country? Only neuraminidase inhibitor, oseltamivir. The other neuraminidase inhibitors like peramivir, which is IV, and inhaled like zanimivir and lanimivir are not available in India. So oseltamivir is the most widely studied and available. The newer antiviral baloxavir recommended by WHO has a different mechanism of action, not neuraminidase inhibitor. This is under trial in our country and not yet licensed for use. So today we have to only talk of oseltamivir, which is the only drug available in our country. And it has a very long history. It was approved for medical use in the US in 1999. It is the first neuraminidase inhibitor available by mouth. It's a selective inhibitor of neuraminidase enzyme of viruses A and B. And oseltamivir is the prodrug which is converted to the active form of oseltamivir carboxylate in the liver. How does it work? It stops neuraminidase from acting, and it inhibits the influenza virus from replicating. So in a sense, it stops the disease in its tracks and prevents further spread of infection. So virions are not allowed to be released, and virion replication is stopped. So this is how it prevents the spread of flu in the body, and therefore it limits the disease. So with this short foundation facts, we will now go into a case-based discussion where I'll request both my panelists to come out with the answers. So let's start with the first case. It's a 2-year-old boy with high-grade fever cough and cold. He was interfebrile active initially. Now on third day, he has come with some lethargy. He's quite dull looking, and he has some dehydration because of poor intake. So clinically, it's like an ILI or an influenza-like illness, and we have admitted the child. So Dr. Anil, this is an ILI child. What is the differential diagnosis of ILI? What else can it be?
Influenza-like illness, we think about the non-flu viruses also, because we're in the middle of monsoon season and there is an epidemic of respiratory viruses going on. So we think about the non-flu viruses like we always had, like a enterovirus, rhinovirus, adenoviruses, which have been there. Like we are just about coming out of an epidemic of adeno. Adeno is still around. We need to think about the other viruses like adeno, and also the great mimicker like mycoplasma, these kind of respiratory things we should be thinking about.
Okay. And Mukesh, is there any non-influenza, is there any non-respiratory condition predominantly which we can confuse with an influenza-like illness, especially in the monsoon season?
Yeah, so when the initially child comes with fever and a slight cold, you have a long list of differential diagnoses, be it dengue, be it malaria, be it leptospira. But I think once in a while, even dengue can come with slight respiratory symptoms, though classically we talk about dengue without respiratory
Dengue was
symptoms.
always thought to be
So we can confuse with
disease without Qatar, but as you rightly said, we can get respiratory symptoms in dengue. So dengue remains a differential of ILI, right?
absolutely.
Yeah. So Mukesh, how do you distinguish between a severe flu versus a non-severe flu?
So the reason why you have to differentiate is, one is to investigate, two is to hospitalize, three is to start therapy. So you're looking at certain clinical clues. Is the child inactive? Is the child unwell between episodes of fever? Is he listless, apathetic, not accepting feeds, not sleeping in the night? He's tachypneic, his vital parameters are awry, his saturations are dropping, or he's among the high risk groups. So all of these tend to make you worried.
Yeah. So as you rightly pointed out, the WHO guidelines say that serious flu means sepsis, septic shock, severe pneumonia, acute RDS, multi-organ failure, and exacerbation of chronic underlying diseases. So a child with serious flu typically needs hospitalization, may require oxygen, may require high flow nasal cannula, may require mechanical ventilation, etc. And the mortality rate is also quite high. So we should not underestimate severe flu, because flu is a virus that can cause mild to severe symptoms. Dr. Anil, is there any other system that the flu virus can attack, which you have seen in your practice? And
Yes, sir.
Yeah.
Because flu comes with a very high grade fever of sudden onset. So CNS is the first organ which kind of takes a hit. So we see lots of children coming with febrile seizures per se because of the high grade fever. They may go on to develop a status epilepticus, very rarely febrile deliriums because of that high fevers, 104 fever, and the child is not responding well. So they may be delirious, or they may be completely encephalopathic. After a seizure, they may not recover. So this is one form of a CNS kind of a manifestation. Also, we should not forget that it's a multi-system kind of involvement.
Right.
So if it's left untreated, we may have some hepatic involvement and kidney involvement and all, but that is much later on. But predominantly we see respiratory, CNS, and later on the other system
So I
involvement.
think we should have a healthy respect for the flu virus and therefore tackle it in time. So Dr. Mukesh, what will be your management here of this child who has been admitted with 3 days of fever, lethargy, and an ILI-like picture?
So obviously you're going to rehydrate him, provide him oxygen if he's having a desaturation or his vitals are awry. And you send your initial list of investigations. Pending investigations, you would start an antiviral drug because there is a influenza epidemic going on. The child is unwell. He is hospitalized. You initiate oseltamivir. You send the initial work and see what comes back.
So you'll start Oseltamivir here and also probably send the nasopharyngeal swab for influenza.
Absolutely.
Yeah. So now I'll take another case with a little different presentation. This is an 18-month-old boy, Shlok. There is a past history of a typical febrile seizure. He has fever. Day 2, he comes to you. And the mother tells that sometime back he had another typical febrile seizure, but now in the clinic he's playful and active. So you did not think that he required admission. He was sent home on symptomatic treatment. Intermittent high-grade fever continues, but the child is active in the interfebrile period. Now the mother brings him back again the next morning and she says she has one more short-lasting episode. So this time you admit the child, right? So what I want to know is that now by the time the child is admitted and you have gone to see the child in hospital, again, the child is active. This was after 2 hours later. So now this is a situation where you have an ILI, but Dr. Anil, will you give oseltamivir to this child?
Yes, sir. This child is 18-month-old coming in that high risk category group. Anybody less than 2-year-old will fall in the high risk category. So even though we have admitted this child for recurrent febrile seizures, maybe it's the second episode or the third episode of febrile seizure. So to prevent the progression or till we have the further investigations coming back to us, I think it's worthwhile to start him on oseltamivir, especially in this season of the epidemic that's going on.
Correct. So even though the clinical picture may be active, but the child is admitted and the child has multiple seizures, so you want to remove the cause of that fever as well. And therefore here oseltamivir is to be given to this child anyways. So we did the flu swab and the flu swab was a little peculiar. It shows influenza A. I'm sure you can't read this, but I'll just tell you all this, that influenza A was detected, but this child did not have either H1N1 or H3N2. It was an altogether different strain. So, do you think, Mukesh, the strains matter? Which one comes in the flu swab?
If you're talking to us, for us clinicians in terms of therapy, no, they would not matter because our drug covers all of them. And our decision to admit and start is not based on which strain it is. But in terms of epidemiology, in terms of epidemics, in terms of our studies, yes, they would matter. And then
Yes,
some
for the
strains are
community.
zoonotic. So in terms of tracing the source and the spread of the epidemic, that would help. But in
Right.
terms of our practice, no.
Yeah. All right. So this, now I'll just tweak the case a little bit. This same patient has come to you on OPD basis on the third day. There is no history of seizure, but the child was active when you saw. Mother says intake is okay. It's not normal, but he's taking and he's passing urine. In this OPD patient, will you start oseltamivir? Dr. Anil?
No, sir. This would be a straight away category A OPD kind of a patient who is active and good oral intake and mild symptoms. Really doesn't warrant to be treated with oseltamivir if he were to be a OPD patient.
Yeah. So now I will ask Dr. Mukesh that which are the children in your practice or as per the guidelines where you will start oseltamivir upfront? Can you tell me whether there are any such children?
So your concern is in which patients would influenza become potentially harmful, severe and fatal. So the child below 2, the adult above 65, a child with a chronic lung disease, be it a preterm with bronchopulmonary dysplasia or otherwise, cystic fibrosis, asthma, a child, a congenital heart with left to right shunt, a sickle, a nephrotic on steroids, a primary immunodeficiency, an HIV, secondary immunodeficiency. So any child who is at high risk would qualify for initiating oseltamivir irrespective of the severity of symptoms.
So upfront, you will start in children who have a concurrent problem, who have a chronic pulmonary disease, as Dr. Mukesh said, a cardiovascular disease, a kidney disease, a hepatic disease. And now, interestingly, one more, this is from up to date, apart from immunosuppression, obesity has become another reason. So if the child has a BMI of more than 95th percentile, this is the child who will require oseltamivir upfront because of chances of complications are higher. And also cerebral palsy, epilepsy, CNS problems. All these are the situation where even if you don't think it's a severe flu, you will still start oseltamivir upfront. Is there any other indication, Dr. Anil, other than the child's condition, where you will start oseltamivir to the child?
Yes, sir. Apart from the direct,
he's not a child requiring oseltamivir per se, yet you have started oseltamivir. Can you shed light on such a
yeah. If it's not a direct indication, sometimes we need to fall back on the epidemiology also and from where the child is coming. Just to protect the caregivers, there may be a high risk parent at home who is having any of these high risk conditions that we discussed about, or there may be an aging grandparent at home who is like, as we know, the immunity is waxing and waning towards the either end of the spectrum. More than 65 or less than 2 years, the immunity is less. We will have to go ahead and start. Just to protect the other caregivers at home, we will have to start sometimes.
Yeah. So sometimes oseltamivir is given to protect the high-risk contacts. They may be elderly grandparents with comorbidities, or they may be even a young person who is on immunosuppressants, or they may be a very small sibling who is below the age of 2 years, or especially around 3 years and around or so, who is very vulnerable, and therefore you have to start this, or a child who is very young. So you will start if it's a newborn, if this child has a newborn brother at home, or a small sibling, you may start oseltamivir in this child with the idea that the high risk people at home are also protected. Now, I'll ask questions to both the panelists. So, Mukesh, have you ever used oseltamivir in a situation where there are non-respiratory presentations?
So
And
if I have a serious child in the ICU where the margin for error is very small, then you would resort to polytherapy. You would cover him pending investigations. And so in an epidemic situation, even so-called non-flu-like symptoms would warrant use of the drug pending investigations.
yeah, so in a non-respiratory patient, like say a child where you suspect a cerebral, where you suspect an encephalopathy, or you have not actually thought of flu alone, but it may be that in a flu season you want to cover a serious patient, so then you will still use oseltamivir. Is that right?
Absolutely. You're
Yeah.
justified. Yes, yes.
Dr. Anil, if I had a child who came with high-grade fever and diarrhea, and this is the middle of the flu season, would I think that this could be an intestinal presentation of flu and therefore start oseltamivir?
Diarrhea is one of the mucous membranes, and just isolated diarrhea, we would be very wary of starting oseltamivir. But if
Right.
it's a multisystemic illness, probably starting with some respiratory kind of a symptom and then goes on to develop high-grade fever and little bit of GI symptoms, yes, probably this will qualify to be treated with oseltamivir.
Possibly for
Not just
diarrhea.
the isolated
Right.
GI symptoms.
So for diarrhea alone, you would not start, but if it's a diarrhea with concurrent other symptoms, probably you would want to start.
Right, sir.
I want to ask
Also,
you as
Prakash, if the same patient was in the office practice, you would not for atypical symptoms. Only in the hospitalized patient where the
yes.
margin for error is small, would you err on the side of starting in an atypical presentation?
All right. So now I want to know, as both of you as busy practitioners, do you always do a flu swab? Meaning there are two situations where you have the chance to do a flu swab. You suspect flu, you do a swab, and then depending on the report, you start oseltamivir, or you you suspect flu, you send a flu swab, but without waiting for the report, you start oseltamivir. So do you actually send a flu swab in the context of oseltamivir? First Mukesh and then Dr. Anil.
So you have a hospitalized patient in the ICU, in the wards, who has danger signs. You're admitting him, you're starting oseltamivir and sending a flu swab. In the office practice, you are not doing the swab and you're starting patient oseltamivir only in the high-risk patient. So the hospitalized patient, you send a swab. For the patient in OPD practice, you don't.
All right. What about you, Dr. Anil? What's your policy?
Yes, sir. Same thing. We do start investigating with the swab only for the category B, that who are moderately sick and severely sick kind of a patient. And also here, I would like to mention the resource because we are all practicing in metros. It's fine, but if someone doesn't have access to these kind of tests, let's say there is no testing facility, PCR testing facility available, they should still follow the guidelines, category A, B, and C. Again, in category B and C, who are moderately sick to severely sick, even though the swab testing facilities are not available, better to go ahead and start them on empirical oseltamivir, even without the swab.
Okay. So now, suppose you have started oseltamivir and now the flu swab is negative. So we all know that the sensitivity and specificity of the flu swab is excellent. Mukesh, can you tell us in short, what is the specificity and sensitivity of the flu PCR from the
Yeah,
nasopharynx?
so if done properly at the right time, it has an excellent sensitivity, specificity, a sensitivity of more than 95% and a specificity of 100%. So ideally, if it is collected properly and you get a negative result, you are pretty confident it is not flu. But if the swab is not collected properly or it is done late when the shedding has reduced, then your yields will drop.
So to simplify matters, if what it means is, what Mukesh is saying is that if you identify the flu virus in the PCR, the chances that your flu patient actually has influenza is close to 100%. On the other hand, if you're suspecting influenza, the chances, and if it is genuine influenza, of the patients of influenza, almost 90% or 95% will show the virus from the swab. So it's a very good test. So which brings me to the corollary that if the swab comes negative, what would you do? First, Dr. Anil, and then Dr. Mukesh.
Yes, sir. Two situations. If the child is severely sick in the ICU and there is nothing else to be, there are no other symptoms to explain, there is no other alternative diagnosis. Even though the swab is negative, if the child is sick, I would continue and complete the full 5 days of therapy. And also, let's say if the child is not sick and we don't have a other explanation to it, we don't have any other localizing sign, and the fevers are still there, I think it's worthwhile to continue it and complete it for 5 days.
Okay. Dr. Mukesh?
Spot on. I think I agree with what Dr. Anil says.
Right. So I think one has to go on a case-to-case basis. WHO says that if the swab is negative, you can stop the treatment also. But however, in a seriously ill child and you're not even sure whether the swab is collected properly, you're late in the disease, it is in a serious situation, you will still continue oseltamivir. In a non-serious one, or if there is an alternative explanation. Now, sometimes what happens is, in many of these hospitals, our swabs are bundled. A flu swab comes with an RSV, with a COVID. So if you have your RSV virus there, then why would you continue flu? But if you don't have the complete answer, then it's best to continue, especially if the clinical context demands.
So,
So-
Prakash, then somebody in the audience will ask you, if it is coming positive, you are giving oseltamivir, continuing. If it is coming negative, still you are giving it. Then why are you testing?
Why send it at all? So I think if there is an alternative explanation, as I said, if the swab throws up RSV, why will we give? I've had so many instances where the RSV and flu, we have sent a swab, it is RSV, I've stopped anti-flu treatment. But so that is a chance you have to take, and especially if the patient is seriously ill in an ICU, you want to know where you stand. You want to know very sure. So therefore, sending a swab is definitely good clinical practice.
Also, your confidence not
Yeah.
to escalate antibiotics is there. Once you get a flu bug, then you're slightly on more secure ground, not becoming too aggressive with other therapies.
To play the devil's advocate, I mean, we'll come to that in more detail in a little later. That sometimes you may feel that the child is critical and I'll still give an antibiotic. But I'm sure it has a role in AMS, and we are coming to that in some time.
Right.
So this is a chart from Up to Date about antiviral therapy with suspected or confirmed influenza. Now, if you see that children with severe illness, non-severe illness, everywhere the agent is oseltamivir. At 5 through 6 years, it is oral baloxavir as an option, but not an option in our country, not available. Age more than 7 years, the options are first oseltamivir and then inhaled zanamivir or oral baloxavir and IV peramivir. None of these are available in our country. So for us, it is oseltamivir all the way, whether it's severe illness, non-severe illness, or even prophylaxis. So now I'll come to one more case. I have a breastfeeding mother who has a 6-week-old baby, the mother has influenza symptoms, and her physician has decided that he wants to start oseltamivir. So the mother, however, is a little bit jittery about this, and she calls you as her pediatrician and says, Dr. Anil, is it safe for my baby if I take oseltamivir? What will you say?
Yes, sir. The safety profile of oseltamivir is quite clear for us, as in when we use it more and have more confidence in it. So I think it's pretty safe even for a breastfeeding mother to go ahead and take it. As for treatment or for prophylaxis, I think it's quite safe for the mother to take it.
So you will encourage her to take oseltamivir?
Yes, sir. And in the bargain, we are protecting the baby also.
Yes. Mukesh, you want to add something?
Spot on. I guess the baby is at high risk for severe influenza. By administering it to the mother, since we can't give it to the baby, we at least protect her indirectly by giving the mother oseltamivir, treating her influenza, and minimizing the transmission.
So I think here you would say that you definitely encourage her because the baby gets protected, and pregnancy, she's recently been pregnant, and the baby is a vulnerable baby. So if the mother transmits virus to him, it can be dangerous. So best is that the mother should take oseltamivir definitely. And there is no problem in a breastfeeding mother, as well as it will give enhanced protection to the baby as well. So
superb safety profile.
And very good safety profile. So now my question to both of you is, this is a vulnerable baby. Does the baby need prophylaxis at 6 weeks of age? Dr. Mukesh first.
Yeah, so guidelines don't allow it, though
Yes.
child is at high risk, but and below 3 months we cannot use for prophylaxis. So this child would not qualify for prophylaxis, but would qualify for an early treatment of the mother.
Right. So the baby, though, is vulnerable. The baby requires possibly, but the recommendations say that he should not be given prophylaxis unless the baby is symptomatic, in which case you'll start full-fledged oseltamivir in the baby, right? So what is the youngest age, Dr. Anil, to give oseltamivir? Is there any youngest
Yes.
age?
According to literature, sir, it says 14 days is the required age where the babies can be treated with oseltamivir for a full treatment basis. But
Yes.
when it comes to prophylaxis, the recommendations are that we don't use prophylaxis for babies who are younger than 3 months old. I think we
Okay.
should be careful here. But again, if the babies are little sick, they're in the ICU. Let's say even let it be a pretermer baby also, or 28, 29 weeker baby also. If they're sick enough, they need to be treated. We need to consult the ID specialist, make sure we're using the right dosages, because here the dosages may vary to almost 1 mg per kg or even 1.5 based on the age of gestation, and we need to use the right dosages, and this can be used for treatment. But when it comes to prophylaxis, 3 months is the cutoff.
So the take-home message is that for prophylactic oseltamivir, 3 months is the cutoff. Don't give it to a younger child. When it comes to therapeutic oseltamivir, it is licensed above 14 months, 14 days. But if the child is critical, sick, really flu-like, it can be used even at a younger age, from 0 to 3 months. The other thing is that even preterm babies who are more than 28 weeks, 28 weeks and above, they can safely get oseltamivir, but the dose is a little low. So we recommend that you look up the doses before giving it to a very small preterm baby. And for a preterm below 28 weeks, you have to consult with an ID specialist to decide whether oseltamivir can be given. But in short, there is really no youngest age. Depending on the need, you can give it at any age. Let's take one more case of this 11-year-old boy who has come with history of fever, vomiting, cough, cold, and altered sensorium since the last 2 to 3 days. Clinically, there is an encephalopathy. The X-ray is showing haziness of the right lung. And the child was intubated in the ER and shifted to PICU for further management. Lumbar puncture was done. The CSF was normal. And he was started on IV antibiotics after sending blood culture. IV antiviral means acyclovir and other symptomatic treatment. So the lab on admissions were quite unremarkable. Dengue, malaria, everything negative. But the multiplex PCR from the nasopharynx came positive for influenza A H3N2. CSF meningitis panel was negative. So Mukesh, I'm asking you here that in this clinical scenario, first of all, the patient has reported to you on day 4. Is it too late to give oseltamivir? A, is it required? And B, is it, even if required, is it too late?
So while guidelines say that the best use of oseltamivir is in the first 48 hours, so we try to strive to start the drug as early as possible. However, in critical situations where the diagnosis is strongly suspected or the child is very serious and where we are doing polytherapy to start off with, you must start oseltamivir irrespective of the day on which the presentation is made to you, or the day on which the diagnosis is made. Does not matter. You would give this child the benefit of doubt and send him on oseltamivir given his serious condition.
So I'll give a clear take-home message that it is never too late to give oseltamivir. If the child is sick, give it even later in the course of the
Fair
illness. Yeah. Now, Dr. Mukesh, Dr. Anil, this child's father is a very Googling sort. And he tells you that, doctor, the CSF meningitis is negative. I've seen the report. Then why are you putting my child on an antiviral drug when you have not even proved that it is flu? So what is your answer to that?
The way the flu affects the CNS may not be a direct invasion. So we know about the cytokines which are being released, the bad cytokines, which are the IL-6 and the other cytokines. These are the cytokines which play havoc in the CNS. So obviously we won't be able to demonstrate and the virus per se in the CSF. So as a surrogate marker, we make use of the respiratory, because this child started with cold cough. It's a respiratory focus to start with. So surrogately, we do demonstrate the virus in the respiratory panel, and we the role play of these interleukins and all come in play, and then the CNS gets affected.
So in
So
this
obviously
situation, carry on.
obviously the cell count in the CSF is going to be negative, and we won't be able to demonstrate the virus in the CSF panel, and it doesn't contain one.
Yes. So Dr. Anil has clearly brought out 2 points. A, you don't have to show the virus in the CSF because the impact on the CSF may be indirect based on the cytokines, like an autoimmune reaction. And the second thing is that anyway, the viral panels do not contain meningitis, the so-called CSF biofire. It does not contain influenza. So so if that panel negative has no meaning, but in the interest of the child, you will use the PCR as a surrogate marker from the nasopharynx and give the child oseltamivir as well. So the neurologist also said it is encephalopathy. The child continued to have fever spikes. You started the child on oseltamivir, and after a day or two, this child developed features of acute kidney injury. So, Dr. Mukesh, do you think the influenza virus can cause AKI?
So virtually all viruses, like they affect multiple mucosas, they can affect multiple systems. Be it doesn't restrict itself to the chest. You have CNS symptoms, you can have renal involvement, hepatic involvement. Though in clinical practice, seeing acute kidney injury with influenza is extremely rare but not unknown.
Yeah, so definitely kidney injury is reported. I've seen case reports where influenza virus can cause AKI as well, acute kidney injury. So we should have a real healthy respect for the influenza virus, which not only is a respiratory illness, but can involve the CNS, kidneys, etc. So one thing is never too late to give oseltamivir, and uh, it can be administered even later on. So this is a WHO algorithm for treating influenza, suspected or confirmed influenza. If influenza is severe, give antiviral oseltamivir. If the patient is at high risk of progression to other illness, that means patient with a comorbidity and patient at extremes of age, give antiviral. If either of this is not there, don't give. Regarding prophylaxis, we will discuss in a little detail a little later. And let's go to one more case. So, Dr. Anil, this is a 6-year-old boy who has come to you with an influenza-like illness. And because the child has become a little dull and it is the flu season, you tell the mother that I'm putting your child on oseltamivir on day 3 or day 4. But the mother protests here, doctor, you only have given him flu vaccine. Why do you want to give him oseltamivir also? What is your reaction to that?
Yes, sir. Counseling becomes difficult, but we can always explain them that the flu virus itself keeps on changing. There are the
Yes.
different strains of viruses. The virus itself goes through this slow shift in the antigens on the virus to cause a slow drift, or it can be a sudden shift also. Suddenly, that can mutate to form a new strain of viruses. And also, like, sir, what you told in the beginning, there are multiple strains of these viruses, influenza A, B, and all these other things are there. So whatever, at best, our vaccine will have 60 to 70% efficacy. When we are going to give the vaccine, we are going to prevent against the severity of the disease, but it may not prevent against all the virus strains. So it's essential that we, even though whether they're vaccinated or not, whenever the symptoms are like ILI, we need to go ahead and treat with oseltamivir.
Dr. Mukesh, what is your counseling in this situation?
Absolutely spot on. We have multiple substrains that occur in the same epidemic. And Prakash, this is a real life situation because just 2 weeks ago, I had a family from TIFR, Tata Institute of Fundamental Research, and their child developed influenza and was hospitalized. When the swab came back positive, the father brings out my file and tells me, but doc, you have vaccinated this child for influenza. How did my child still get influenza?
Right.
And obviously, in a busy day practice, you're not going to explain the efficacy that is only 60%, 70%.
Yes.
All that explanation had to come out now. And I was a little bit on the back foot. But you have to put the facts in front of them. I don't know how convinced the parent was, but that's how it is.
So at best, the flu vaccine has an efficacy of at best 60 to 70%. And this the patient should be aware of. So because in spite of that, you can get flu, and giving oseltamivir is not, giving a flu vaccine does not mean that oseltamivir can be completely excluded from the therapy. So the treatment should be initiated regardless of the patient received a flu vaccine, and it should not be delayed. Sometimes what happens is that a negative rapid diagnostic test does not exclude influenza. But here we are not talking of a rapid diagnostic. We are doing the PCR. So PCR can exclude. But sometimes what happens is that the there may be multiple viruses affecting. So if you get an RSV positive, it does not mean that there is no flu simultaneously. Many times I have seen RSV plus flu, COVID plus flu. So two viruses can also be there. So I think however, the vaccine given or not does not influence it. So we have all used oseltamivir quite regularly in the last flu season. So what I would like to know from both of you is, are there any adverse reactions? Please share your experience. Dr. Mukesh, does
So I think
oseltamivir have
oseltamivir
any
is a
adverse
drug.
reaction? Yeah, sorry.
Oseltamivir is a drug which is pretty beautifully tolerated. Adverse effects are minimal. Serious side effects are virtually unknown. At the most, a little bit of gastritis, a little bit of gastroesophageal reflux. Most of them don't require any therapy. So by and large, a well-tolerated drug.
So a lot of people write PPI as a part of the flu of the oseltamivir prescription. What is your comment on that, Dr. Anil?
No, sir, not always required. Only in the cases who keep coming back to us on day 2, day 3, sometimes they keep on vomiting after each and every dose. Maybe that time we can counsel them, break it up into much smaller aliquots and give it more repeatedly. And
Right.
sometimes, yes, a PPI or an antacid may be required.
Oseltamivir is a beautifully tolerated drug by and large, but in my practice, I do not use PPI upfront. But if the child has any GERD symptoms, I would use the drug required. Sometimes I use antacid, or sometimes I use ondansetron to reduce the vomiting, or I may rarely use a PPI. But I think it is not to be bundled with oseltamivir upfront. And then there are some adverse effects of so-called neuropsychiatric disturbances of oseltamivir. Have you either of you seen them? And what is your comment on that, Dr. Mukesh? First.
By and large, we don't see any side effects at all with oseltamivir, let alone serious side effects. So a drug which is very well tolerated, and the CNS symptoms may be primarily because of the disease and not the drug.
So this is exactly what they found in Japan. That Japan, it is very widely used. Oseltamivir and other neuraminidase inhibitors. They found that people do have neuropsychiatric effects like delirium, hallucinations, confusion, etc. But causality, the cause and effect relationship has not been established yet. And some of these adverse events may be related to the influenza virus rather than to the drug. Dr. Anil, have you had any experience of such side effects in your practice?
Not really, sir, not really. Just that high-grade fever can make the child sometimes delirious. Apart
Right.
from that, from the drug per se, and never had any problems.
Okay. So now another common question which parents ask is that, okay, you have diagnosed influenza in my child, you treated the child. Tell me, doctor, when can my child go to school? So they want to send a child to school as soon as possible. It allows them to take less leave, and the child also is like quite restless at home, not manageable. So Dr. Mukesh, what is your advice in this situation to the parents?
The concern is you have to keep him away from other children till viral shedding occurs. So as guidelines mention that once child is ephemeral for 24 hours, you can send him back to school.
So this is the guideline by the CDC that if 24 hours the child has no fever without using antibiotics, you can send him. But by then, Dr. Anil, has the viral shedding really stopped?
Not really, sir. I think our primary responsibility as pediatrician is not just to protect this child, probably to advise them correctly that the child should not go back to the daycare and spread it in the among the daycare, other children in the
Daycare as well as the
daycare.
nursery. So well said,
Yes.
Dr.
So I
That
think we should tell them 5 days, at least 5 to 7 days of viral shedding period. Better to keep them back if they have grandparents or someone else to look after this child. They will
yes.
need to be at home, and only then they can be sent back.
So we all know that the real life works differently. Whenever you tell them that don't send your child for 5 days, usually after one day the fever is gone, the child is back to school. This is what most parents do, and that's why the virus is transmitted right and left, and we get so many cases of flu. But one of the parents today asked me, Doctor, you are given oseltamivir antiviral. Now why can't I send my child? Because there will be no virus now. So what is your comment on that, Dr. Mukesh?
So yeah, so if oseltamivir reduces the duration of symptoms by 1 day, we expect it to reduce viral shedding earlier also, but our guidelines remain the same.
Yeah, so CDC says that the recommendation of sending applies regardless of whether the child received antiviral or not, immaterial. Okay, now in a flu season, many times when a child comes with high-grade fever, cough, cold, and the child is sick looking, many of us are tempted to start antibiotics. So do you feel that diagnosing flu right, giving oseltamivir in time, does it help with antimicrobial stewardship in any way, Mukesh?
I think it does. Let us
Hmm.
look at the hospitalized patient. We initiate multi-therapy in the serious illness, but once you get a diagnosis, we tend to pull out antibiotics. Also, once you have a diagnosis in the stable patient, we will not use antibiotics.
Right.
Similarly, in office practice,
Yeah. Yeah, you were
similarly
saying.
in office practice, when you have a clear epidemic, you would prescribe oseltamivir and you would be tempted not to use another antibiotic. So yes, I think it does help in both situations.
So diagnosing right and treating rationally with oseltamivir does help in antimicrobial stewardship. This was an interesting study from the UK, which showed that there were a huge number of antibiotic prescriptions at one time during the flu season. And once they started using the tests and giving oseltamivir, those antibiotic prescriptions came down substantially. So at the same time, sometimes I wonder whether is there any overuse of oseltamivir in our practice? And I would like both of you to comment on that. Dr. Anil first.
Yes, sir. Definitely, oseltamivir. Sometimes, when it comes to prophylaxis, I think like what we discussed, sometimes it is prescribed to anyone and everyone who comes in contact with the child. That should not be done. So that will, because we are always thinking about the development of resistance. So for a healthy adult, contact prophylaxis may not be required. But at
Yeah,
the
we'll come to
same time,
prophylaxis in a minute. But
yeah.
yeah, but I just wanted to know whether do you feel that diagnosis does help in antimicrobial stewardship, right?
Yes, sir. Gives us a lot of confidence. Having a flu swab report.
I think as Dr. Anil has perfectly mentioned, that gives us confidence in withholding the antibiotic there. So this is a child, I can give you an example. It's a 10-year-old boy with presentation of fever with rigors, headache, and the child had a little large tonsils with pinpoint with two white streaks on the tonsils. So my resident doctor who was with me in the OPD said, "Sir, this is follicular tonsillitis. Shall I start coamoxiclav?" But to me, it looked clearly like a tonsillar crypt with a food particle stuck on it. There was no lymphadenopathy, there was no halitosis. So I said, no, let's wait. And we did a flu swab. The flu swab showed influenza A. And this way, we could really avoid antibiotic where it was not required. And the child did well on oseltamivir. So yes, it does help. So I will take one more case quickly because we are running out of time. So I have an 11-year-old girl with fever since 2 days, difficulty in breathing, and associated with post-tussive vomiting, bad cough, bronchospasm. And she was admitted last month with influenza A to another hospital. Now, Dr. Anil, she has come to you with this clinical picture. And you have started her on HFNC. You're given ceftriaxone, Dexa, and you're given. Should you be giving oseltamivir again to the child who has received oseltamivir just last month? What is your take on this?
Yes, sir. This child appears to be pretty sick because needs to be on HFNC and quite sick looking. Irrespective whether she's been treated, diagnosed with influenza A elsewhere last month, I think this child deserves to be on oseltamivir because of the acute febrile respiratory symptoms which have come back. And we know that there are more than one strain of influenza which are going around. And different strains are there, and definitely we need to think about it and start them on an oseltamivir till the things become more clearer.
So you again put your finger on it. We did the flu swab, and the flu this time showed influenza B plus RSV. So definitely back to back 2 months, the child had to be given oseltamivir because first time was influenza A and then it was influenza B. Unfortunately, had not received vaccine in between. So subsequently, we gave the vaccine as well to the child. So this is the X-ray of the child who came and required a PICU admission. Uh, but sometimes when the child does not do well with oseltamivir alone, we are tempted to add an antibiotic. So, what are the indications, Dr. Anil, for adding antibiotic during oseltamivir therapy?
So if there is the response to therapy with oseltamivir is less than inadequate, say even in 48 hours the fever continues, or there is a transient improvement and then again the child starts spiking fever, there is continued requirement of oxygen even after 48 hours. If things are not improving, that's the indication that, or if there is a localization, there is a lobar involvement, there is a dense pneumonia which is kind of consolidating in one place, that those are the indications where we would go on to add on IV antibiotics when it is required.
So, flu is one of the illnesses where the virus makes the patient prone to secondary bacterial infection, and the commonest offender there is strep pneumoniae. So in a child with flu on oseltamivir, not really doing well in spite of the flu being proved, especially if there is a focal pneumonia or the child continues to run high grade fever, continues to have neutrophilia with high CRP. It looks like that there is a secondary infection, and there you may add an antibiotic, but then always have the patients to wait before adding.
Right.
And empirical antibiotic use should not be there, and only when there is a bacterial co-infection. So now we'll come to the last part of this, that when do you give oseltamivir as a prophylaxis? And in the interest of time, I would request both of you to just give quick short answers. So you have a child admitted to you with flu, the flu swab came positive, you have given oseltamivir, the parents are attending the child in the hospital and they will be with him at home. So would you give oseltamivir prophylaxis to the parents of an admitted child? Dr. Mukesh.
So you would give it if that parent is at high risk, above 65, or having immunocompromised condition on steroids with a interstitial lung disease. So
So
high risk parents, you would give it.
So if the parent happens to be on some immunosuppressive therapy like steroids or maybe anti-malignancy therapy, yes, then you would give. What about the parents say now we are taking him home? Both the grandparents are around 80 years of age. So are they at risk from my child? Should I give them some medicine? What is your answer, Dr. Anil?
Yes, sir. Definitely. I would also explain them more than the medicine. I will also explain them the hand hygiene things and isolation, the cough etiquettes and all that. And
Yes.
of course, if they're 85 plus, we would go ahead and start them on oseltamivir prophylaxis because they
Oseltamivir.
are at a very high risk age group.
So anyone who, as we mentioned, the indications for a high risk prophylaxis should not be indiscriminate. Also, the mother says that the mother was not there with the child, and because the father had to look after, because the mother has just delivered a young baby. So if the young baby of now who is only 15 days old is there, would you give prophylaxis to this young baby?
No, sir. 15-day
No, you would
old,
not.
it's not recommended that we
Right.
put
But
them on
around 3 months
prophylaxis.
old, you will give prophylaxis, right?
3 months and above will require prophylaxis.
So what is the prophylactic treatment of oseltamivir, Dr.
So
Mukesh?
once a day dosage, sir. Instead of twice a day dosage, it's a once a day dosage, 3 mg per kg for children less than 2 years of age. 3 mg per kg, once a day dosage can be.
And for how long?
This will be for 7 to 10 days.
10 days.
7
So,
days.
so curiously, the therapeutic dosage is for 5 days, but the prophylactic dosage is for 10 days.
Right.
So post-exposure prophylaxis is for only individuals who have extremely high risk of hospitalization and should not be arbitrarily expanded, and it should not replace influenza vaccine. Vaccine has its own place. Now, I had a child admitted with me last week, a 10-month-old child who came with croup, who was quite sick actually, high-grade fever, lethargic child. Child had laryngotracheobronchitis. We did a nasopharyngeal swab there, and we found we found the para-influenza virus. So, Dr. Mukesh, this para-influenza virus, if I find, should I be giving oseltamivir here?
No, you should not. Oseltamivir will not cover it. It covers all kinds of influenza A, B, but it does not cover parainfluenza.
So let's understand that influenza in the name is not a signature for influenza's sensitivity to oseltamivir. It is just called para-influenza, but it has no role. Oseltamivir has no role in that. So in your practice, what are the contraindications to oseltamivir, Dr. Anil?
Almost nil, sir, I would say, because of the excellent safety profile. I think there are no absolute contraindications. Any proven hypersensitivity is there for the first dose, then probably it's an absolute contraindication. Apart from that, only if there is a renal dosing that is to be required, if the child is having a renal insufficiency, we need to be a little careful. Apart from that, there is no absolute contraindication, I would say.
And they also say that if there is a relative contraindication, like the patient may be having GI bleeding or maybe having malabsorption, bowel obstruction, then you can't give because it won't be absorbed, or it is going to be difficult to give oral drugs. But there, of course, you have to find a way around it, because in our country, we do not get peramavir, which is an IV option. So there is no absolute contraindication. There are only relative contraindications. And even if these oral are there, you have to get around them. So what about pregnancy, Mukesh? Is a pregnant woman allowed to take oseltamivir? Is it safe?
So pregnancy is a high risk situation for potentially threatening influenza. So in fact, it's an ideal situation to use the drug. It is extremely safe if used in pregnancy. And so, in fact, it's one of the stronger indications for the use of oseltamivir during influenza.
So a lot of studies have not found any fetal or neonatal toxicity by using oseltamivir. Now, is there any drug interaction with oseltamivir that you two are aware of? Is there any drug interaction?
Hardly any, sir. Hardly any.
No.
Yeah, yeah.
And
And
nothing.
is there any precaution in a child who has a kidney problem?
Yeah,
Oral-
creatinine clearance, we need to calculate the creatinine clearance and adjust the dosage accordingly. That's the only caution that is required.
Right.
Other than that, it's well tolerated. Even in kidney diseases, it's very well tolerated.
And Mukesh, can you just tell us any interaction between the flu vaccine and oseltamivir?
So, unlike killed vaccine, it's a killed vaccine. So, if it was a live vaccine, then obviously oseltamivir would interfere with its replication and stimulation of the immunity. Being a killed vaccine, no issues at all.
So with inactivated vaccine, you can give it even during oseltamivir therapy, though that's not commonly done. But oseltamivir has no interaction with the killed vaccine. Live vaccine is a different story. You can't give the live vaccine for at least 48 hours after stopping oseltamivir. And if you have given the live vaccine, you must try to avoid giving oseltamivir for 2 weeks after that. Otherwise, the vaccine will not work. So there is a problem with the live and not with the flu, not with the killed vaccine. So I think my two expert panelists have given me great answers, and we have covered the entire canvas as much as we could. And I think I really thank them for very good interaction and crisp answers which have enlightened us. To sum up this, oseltamivir is currently the only anti-influenza drug available in our country. It is a very useful drug in prophylactic and treatment as well, prophylaxis and treatment. We have to use it timely and use it wisely, and we should avoid indiscriminate use. With this, I once more thank my panelists and hetero, and I'll stop sharing the screen.
Thank you,
Thank you,
sir.
sir.
Thanks, Anil.
Thank you, sir. Thank you so much.
Use timely and wisely is the right way to describe Oseltamivir. Thank you all of you for your interaction and your inputs. I'm sure the audience has benefited. Thanks, Dr. Mukesh. Thanks, Dr. Anil. Thanks, Dr. Vaidya.
Thank you, sir. Thank you.
Thanks,
Thank you so
Nagadevi.
Thank you.
Thanks all the doctors who took time and attended this session. Thank you, Salesforce and marketing team for their coordination. Thanks.
Thank you, Dr.
Thanks, sir.
Thank you,
Yes.
sir.
Thank you.